Okay, so first of the ventricular arrhythmias on your book is the premature ventricular complex, or what we call the PVCs, or some other people call it premature ventricular contraction. So there is a premature contraction in the ventricular chamber. So basically, PVCs are extra heartbeats that begin in one of the heart's lower chambers, which is what I call which is not what I call, but it is your ventricles. These extra beats, they disrupt the regular heart rhythm and sometimes causing a sensation of a fluttering or skip beat in the chest. So a lot of times you will hear patients saying they felt nothing until they hear or they feel that their heart skipped a beat code. Okay, so as you can see in this slide, PVCs they occur earlier than the next expected normal QRS. Look at the pointer over here in your first slide here. It's wider. The QRS complex is wider than a normal QRS. And then look at their morphology, or look at their shape. It's generally bizarre. It's widened, right? There is no P wave, okay, that precedes the QRS. And the ST segment and T wave is opposite that of the QRS. So again, that thing you don't really need to like be more specific about, but you can really discern, you can really see that there's a funky looking rhythm. We call that ectopy sometimes. And it's usually followed by a compensatory pause, I should say. So by your book, it says PVC is an impulse that starts in the ventricle and is conducted through the ventricles before the next normal sinus rhythm. And I said that earlier. This can occur in healthy people, guys. Okay, just so you know. But it can also be a cause for people with intake of caffeine, nicotine, or alcohol, and these are caused sometimes by cardiac ischemia or infarction, increased workload of the heart, such as your heart failure and tachycardia, digital toxicity, hypoxia, acidosis, or electrolyte imbalances, especially hypokalemia. So if you see this on on your patients with telemetry or tele, and you're monitoring, like, oh, I see that little blip in there, a little ectopy in there. So you may probably think of like, yeah, maybe you want to check the labs first and see the potassium, because a lot of times these potassium are low, the potassium of your patient's low, should I say. Okay, so in the right side of this picture, you would see the subtypes or the different types of your PVC. We do have bigeminy, trigeminy, and quadrigeminy. So when you say bigeminy in a rhythm, the PVC happens every other complex says. So you can see that in this picture right here, the first row. And then for the trigeminy, PVC happens every third complex, and quadrigeminy every fourth complex. Okay, so if you look at the picture, yep, kind of really understand like it's not the same, picture as the cuirasses, because remember this happens in your ventricle. So what is the rate? There will be no underlying. It really depends on the rate, or rhythm, I should say, depending on your rhythm. Is it a sinus rhythm? Ventricular rate is going to be irregular due to an early Q or S, creating one R to R interval that is shorter than the other. But your P to P interval, remember your P's are atrial contraction, so your the PP interval may be regular because that PVC did not depolarize the sinus node. Remember, your sinus node is found in your atrium. Now, the QRS, as you can see, the QRS shape or the duration is going to be longer. The shape is bizarre, as I mentioned, and over again, it's abnormal. Duration is 0.12 seconds. And they are bizarrely shaped. They have widened QRS complexes. They resemble each other. When they do resemble each other, they're called unifocal, but they have at least two different morphologic appearances. They're called multifocal. Again, you don't need to know those things, but any funky looking rhythm, bizarre kind of QRSs, then that's your premature ventricular contractions or complexes. So what do we do about this? Patients with PVC, again, they may be common and increase in frequency with age. However, what medications can we give would be amiodarone or your beta blocker. They are not considered a warning for ensuing VTAC. So sometimes it's we need to just make sure we need to figure out the underlying causes so you're able to treat this appropriately. So with ventricular rhythm or ventricular tachycardia, um, this is found in page 729 to 730 of your book. So anytime we have a ventricular tachycardia, it's a presentation of three or more PVCs in a row. And if you look at this one, it has the one of those googly things where it goes up and down. It's like I call it a mountain, like series of mountains. And that's actually how a PVC would look like. You see, normal people will have them, and um, you can have a PVC where you feel like you feel when where you feel it like you have this weird heart rate or something. Sometimes you don't know you're having them, but if you have three or more in a row, that's actually diagnosed or considered a ventricular tachycardia. Don't forget that. So does that mean that we're going to jump on the patient and do CPR if you see that in their monitor? No. Basically, it just means that we have an abnormality in their rhythm, and if we have ventricular tachycardia or VTach, and if the patient is responsive, we're basically just going to do an EKG and continue to observe. Obviously, we're going to notify the doctor. Check on those lights as well, electrolytes, because this can cause VTAC. If the patient doesn't have or does become pulseless or unresponsive with ventricular tachycardia, we're going to have to do defibrillation. So again, if the patient is unresponsive, we're in they don't have any pulse, we're going to do defibrillation. If the patient is responsive and stable and has a pulse, we are not going to do defibrillation. So remember those difference, okay? We're only going to do EKG and monitor if they're stable. Here, we really want to make sure that what we're doing is to observe and ensure that they're not going to go into AFib or VFib. We're going to probably with a stable VTAC, we are going to probably start on a medication such as sotalol or amiodarone, and we may need to end up doing cardioversion if they're unstable. Obviously, when they're unresponsive and with no pulse, they call it the pulseless VTAC, then we're gonna defibrillate your patient. Okay, so complications for this will definitely lead the patient to VFib, asystole, and death. These are the things that would definitely occur if you don't treat this rhythm. Okay, so for ventricular fibrillation, basically, is the most common cause of this is coronary artery disease and myocardial infarction. So what's gonna happen here? You can see the ventricles are quivering, and they have a rate of greater than 300 beats per minute. It's very regular, and it has no pattern of rhythm. If you look at it, it's just like a squiggly line. So the way you know it's a fibrillation versus tachycardia is that in the tachycardia, it has this higher, tall, like a mountain kind of waveform, and there's some impulse going on up and down. With it's with the ventricular fibrillation, it's just quivering. It's a very small, very irregular quivering type, shorter pattern that your ventricular than your ventricular tachycardia. Signs and symptoms of this: patients are going to have a heartbeat. Are they? They are not going to have a heartbeat. Remember, they're dead. They don't have no pulse. They have no respirations. If you see something similar on this in a monitor and the patient's looking at you and chatting at you, smiling at you, they obviously don't have a ventricular fibrillation, so don't freak out. They probably are moving or the electrodes are hooked onto the sheet. So this is not a rhythm you're going to see in a patient that is talking to you. Remember, these people are dead. So if you see this VFib, or about to be dead, I should say, if you see this VFib, you're going to call a code, initiate CPR, and get the defibrillator. The treatment, early defibrillator or defibrillation and CPR. Also, we can give epinephrine every 3 to 5 minutes, 1 milligram of epi. So you can give a dose of this epi. Also, you can also give a dose of vasopressin. Other pharmacologic interventions would be the amiodarone. You have the the lidocaine, I should say, um, and you can bring back. So you can bring out the patient from a code, and you can Also, I'm sorry, where am I? So amiodarone, lidocaine. Um, Also, you want to treat the H's and the T's if you remember that from earlier. Sometimes if a patient is brought back from a code, there's an ROSC, return of spontaneous circulation, or signs of them. So you can sometimes see these patients in what we call a code cool, wherein the doctors and nurses will cool the core temperature and will decrease it over usually about 12 hours. And then they're going to keep the patient cold like an ice ish for 24 hours. After that, they're going to gradually rewarm the patient again. So when I say gradually, it's not that they're going to pull them right down and warm them right up, or you want to do it over a period of time. They monitor the electrolytes and the sign and watch out for signs of brain damage. So they are all listed in your book as a complication. So, or I mean, as the treatment. So again, the complication for ventricular fibrillation is asystole and death if not treated. Okay, so last but not the least, we have our systole, or asystole, asystole. So the presentation for this obviously is flatline. They don't have a pulse. They don't have no respirations. They have no heartbeat. Obviously these patients are dead. Okay, so signs and symptoms, again, there's nothing, they're not doing anything, they're dead, they're cyanotic, they don't have a pulse, they don't have any respirations. So what we're going to do, obviously we're going to initiate a code, call for start CPR. Medication drug of choice for this would be epinephrine, again, one a milligram up to, or 1 milligram every 3 to 5 minutes. We The only thing I want you to remember, as early as now, okay, we do not want to defibrillate these patients or people who are on asystole if there is no electrical activity. Okay, if you see a flat line, you cannot defibrillate the patient. All you can do is give medications, which is epinephrine or epi every 3 to 5 minutes. Excuse me, and CPR. So start CPR really good. Really quick, get CPR going, and you're going to call your code. So that would be your management for asystole. There are two things that I really want to talk to you about: cardioversion and defibrillation. And I know I keep on saying about defibrillation. And I'm going to show you more pictures or a video about defibrillation after this slide. Remember, the differences with the cardioversion and defibrillation. Well, let's talk about similarity. This both treatments, they treat the tachyarrhythmias by delivering an electrical current that depolarizes a critical mass of myocardial cells, and then when the cells repolarize, the SA node is usually able to recapture its role as the heart pacemaker. The difference between these two is that the timing of their delivery. Okay, so in cardioversion, the delivery of the electric current is synchronized. That's why you hear people say, are we in sync mode, and we can show you that in the clinical setting, where the sync mode button in the defibrillator. So the delivery of the electrical current is synchronized with the patient's electrical events, while in a defibrillation, the delivery of the current is immediate and unsynchronized, because in defibrillation, you need emergent. It's an emergency treatment. It's emergency medication modality or management for patient who is about to die. Okay, which is like VTAC and VFib, pulseless VTAC. So let's go back. Electrical cardioversion again. Delivery of a timed electrical current to terminate a tachyarrhythmia. What are those again? Your atrial rhythm, atrial arrhythmias, AFib, A flat, sometimes your SVT, not sometimes, even your SVT, I should say. The defibrillator is set to synchronize with the ECG and a cardiac monitor so that the electrical impulse discharges. It should discharge. Okay, note, it should discharge during the ventricular depolarization. When is that? What complex is that? Your QRS complex. The synchronization prevents the discharge from occurring during the vulnerable period of the repolarization, which means your T wave, which could result in VTAC or VFib. Okay, so basically you want to make sure it's on sync button, and that the timing of the electrical will discharge in the ventricular depolarization or curious, and not on the T wave, which is your ventricular repolarization. Why? So that your patient doesn't go into VTAC or VFib. Basically, the ECG monitor should be connected to the external defibrillator. The lead should be changed, and it should recognize the QRS complex. So these are things that the nurse should do in this critical situation. It's important to ensure the patient is connected to the monitor and to select a lead, not paddles. So that's another more detailed way of doing cardioversion. And in the next few slides, I'm going to show you where the paddle should be, the standard paddle placement for defibrillation or cardioversion at the same time. Now we're going to talk about cardio defibrillation. It's used in emergency situations. Again, this is your treatment of choice for patients with ventricular fibrillation or VFib and VTAC without a pulse. Remember, VTAC, no pulse, okay, or pulseless VTAC. Why? Because of the abrupt loss of cardiac function and the sudden cardiac death. Again, you do not want to use defibrillation for patients who are conscious or who do not have a pulse. Okay, so then the setting for this, depending on if it's a monophasic or biphasic, again, I don't think you really need to know that, but a lot of times, board you'll learn more of this in nursing form, but I'm going to say it anyway. Monophasic defibrillation should be set at 360 joules, while if it's a biphasic defibrillator, it should be set at 150 to 200 joules, okay? And it increases in those with subsequent shocks. Again, after you do that, immediate CPR is provided, and again, defibrillation is performed within 5 minutes. So after that, you also want to give your epinephrine. So give for any initial unsuccessful defibrillation, again, to make it easier to convert the arrhythmia to a normal rhythm with the next defibrillation. If and other medications we can give aside from epinephrine are your antiarrhythmic medications, such as your amiodarone, lidocaine, and magnesium. So your goal here for defibrillation is continuous CPR, med administration like of what? Epi, amio, lido, and um amiodarone, lidocaine, and mag, or what I call MAIL. Why? Magnesium, amiodarone, lidocaine, and epinephrine. But epi is your number one choice. What else? So CPR, med administration, and defibrillation until a stable rhythm resumes on until it's determined that the patient cannot be revived. After the paddle, I will be showing you, because this would be my, well, second to the last voiceover, but I'm gonna be showing you a video of a defibrillation of a device, how it works, and an ICD, how it works, and then on the last slide is a really good a live video of two cardiac arrest patients, and you could see different stuff in there, how they were defibrillated, and how the patients were, or one of the patients have been um initiated with therapeutic hyperthermia. Again, you don't need to know all this stuff by now, right now, but you just have an idea, and how they were placed with chest tubes. Really interesting. I'm gonna use that slide or that video on the last slide for you to really understand, you know, real time and how we manage patients with arrhythmia. So just to correct my slide here, this is an example of a placement paddle or a pad placement for not only defibrillation but also cardioversion. The first one on the left, it's the standard placement of your the pads when you do cardioversion or defibrillation. And the second picture over here, which is the right side, it's called the antero-posterior paddle or pad placement for cardioversion or defibrillation. So just you're aware that when it's, because especially for defibrillation, when it's time to um put the pads on, you know where to actually put it. So this is a great picture of that for that. So when performing electrical cardioversion, you have to make sure that um, there is a good contact between the skin and the pads and puddles. So you wanna. This is only for the next bullet here that says use conductive medium 20 to 25 pounds of pressure. That's only when you use the puddles of the defibrillator. Um, Most of the time now we're using the pads. So it says here place puddles so they do not touch bedding or clothing. So we are also talking about the pads as well. If cardioverting, as I keep on saying, you want to turn the synchronizer on, and if it's defibrillating, these are cases like ventricular fibrillation, ventricular fibrillation, fibrillation, not atrial fibrillation. Okay, remember fibrillation is cardioversion, ventricular fibrillation is defibrillation. So if you'll learn more about this in nursing 4, but if you are doing defibrillation, you don't need to turn the sync on. Um, this is one of the most important things as well. Do not charge the device until it's ready to shock. Okay. And then when you are ready to shock, you have to make sure you clear. One, I'm clear. Two, you're clear. Three, everybody clear. And everyone should say clear 3 times. Okay. Follow checks required to clear. Make sure that no one is in contact with the patient or the bed or equipment. No one is, if the patient is, or is, if an RT is ambu bagging the patient, make sure she, releases the ambu bag. Let's go, let it go and put it in the bed, stuff like that. Make sure no one is touching the side rails. Um, as long as nobody is in contact with patient, bed, or equipment. So these are just a few of the safety measures. You will also find in chart 26-6 in page 738. It shows you how or what do you do when you're assisting with external defibrillation or cardioversion. Now you're gonna see again two great videos that explains cardioversion even better, and an actual person getting cardioversion. So again, this is more of the videos are for informational purposes only. I believe it's gonna help you fully understand the material if you watch the videos. Um, if you have any comments and suggestions, again, you can email me. But this is the end of my atrial rhythm or atrial arrhythmia or dysrhythmia concept.
When the heart's natural pacemaker is not working properly, the heart may beat too fast, too slow, or irregularly. A doctor may implant a heart rhythm device like a pacemaker or defibrillator to restore the heart's natural rhythm. These devices are traditionally implanted in the upper chest beneath the collarbone and are about the size of a stopwatch. These battery powered devices are connected to the heart with a lead, a thin, flexible wire that is traditionally inserted into a vein into a heart chamber. An internal defibrillator can sense when the heart is beating too fast, called tachycardia. In this case, the device will send small, painless electrical pulses to correct the heart rate. If the rapid heart rate continues, the defibrillator will deliver a necessary life saving shock and restore the heart to a more normal rate.
So this patient's kind of a classic situation. He was a runner, and I think he was at a race, and he went down. He had CPR that was started immediately.
You had two CPRs that came at the same time?
Two CPRs at the same time. Yeah, this one over here was a lady who was observed by her husband, and she went unresponsive and had a cardiac arrest. But we have a heart rate back on her. She was down for some time. We're going to do the hypothermia protocol on him, and we just intubated him, and so that's where we're at. Yeah, I'm not sure if she's going to make it because she's been down for a while, and she was clearly an asystole when she got it, but a little bicarb, we got a heart rate. So we've been in and out. We've been in. Yeah, she is. We're going to start CPR again. She's been in the VTAC. Yeah, push those heavy sounds. Just had VTAC intermittently. Show me what happened on this guy.
All right.
So, okay, so right there, that looks clearly like you've got some VFib going on. All right, and what happened?
We shot, and then they started CPR again.
Okay.
And then we got in a truck, and I realized that he had just started having a rhythm.
Okay, good.
There we go.
There you go. Good job, guys. So one shock. They should have one shock then, right?
One shot.
Okay, this is my little
But
feature
they
video
had
here.
did 12 minutes of CPR prior to us getting there.
Very good. So immediate CPR.
Yes.
Beautiful.
By other runners.
Beautiful. So on his EKG, a little ST segment depression, anterior lateral.
Yeah.
And so, and I guess I get cards involved on this too. So we're getting heart rate back. I mean, blood pressure back. So Jed, you going for a femoral line?
Yeah, we're gonna go femoral line.
Okay.
The interesting thing is, so when we gave the bicarb and we gave D50 at the same time, roughly, that's when we got return to spontaneous circulation. So it could be the acidosis, it could be for sugar. No history of diabetes.
Oh, okay.
And so I wouldn't think she's on anything. But
Okay. Yeah, I mean, hyperkalemia of some kind could do it too.
Or she's in diarrhea, she could have hypo.
Yeah. So you're getting him cold? Getting ready to make him cold?
Yes.
Foley's in?
Yeah.
Good job. Blood pressure's hanging in there. What is it, 121/80? Heart rate's 87. The EKG has some anterior lateral ST segment depression.
Where's that verse at?
Right here.
Am I starting at 5 an hour?
You got
Well, I'm getting on.
You got the line. So you actually got the, okay, good.
Oh, I
You
got the
band.
wire in the line.
Okay, good.
Yeah, no problem. At least just the cold saline for right now.
And since we don't have the other cooler right now, we can just do
I may need you just put
cold saline and ice pack.
Is it connected?
Hey, happy morning. What are you? Where's it going?
Great little push dose epi.
Do you want me to move the epi to? Her creatinine was 6.2
Creatinine was 6.2.
and her calcium's 2.5.
Let's give her some calcium. Have we given her any calcium?
No.
So her coolant therapy while she's down here is just going to consist of the saline.
What do we
Okay.
have in there?
Try and get a
Calcium
blanket
chloride?
all and all up in
Gluconated
NICU.
here.
Gluconade's
When
fine.
she gets
Two.
up there, she'll be started.
Is that how many grams is in that vial?
On the blanket.
Well, this is 100
Okay.
per ml, so this is 1,000.
1 gram. Yeah, let's
Yeah,
just
1
give her
gram.
2 grams.
2 grams, okay.
I just talked to the charge nurse in NICU.
Here's one.
They're aware,
Okay.
and she was
So
going
this
to
is
find.
10 mics per ml.
Yes. So you can do 1 to 2 ml,
Right.
and if you want to be a little more aggressive, you can even do more. But 1 to 2 ml every few
Is this line
minutes.
here in her foot good?
But the IO is probably good too. You can,
Yes, they're aware and
This might be a card.
I think this might be a card. Yeah, I think this might be a card. Because he doesn't.
Syncopal. Witness, yeah.
so his blood pressure's hanging in there really good. That's excellent. He's retaking it. Did it drop?
Not really good.
It dropped a little bit.
It was 123.
Okay. Cold. All that cold would make my blood pressure go up. But we're gonna add some fen up. We're bucking on the ventilator a little bit here. I'm gonna call the cards. Oh, CPR over here.
Let's
Yeah.
go ahead and charge. Resume compressions until she's ready.
All right,
Are you seeing?
I'm clear. You guys clear? Everyone's clear?
I'm not seeing answers.
Clear. Shot.
Resume compressions. Hold compressions for you.
Yeah, I don't see any ants marking on it.
It looks agonal right now.
Yeah, I agree. Check the other side. Go ahead and resume compression. She's got a pneumo on this side.
A pneumo on the right side. Okay, let's do it. Let's do a needle.
Do a needle.
Do a needle
14
first.
gauge angiocath. Let me off. I gotta check this one real quick.
All right, looks like she's back in shape.
Yeah, this one's different. You gotta write that pneumo. Because it's ready to charge. It hasn't been a full time. We're kind of breaking it up. So let's go ahead and compressions. What was that?
The one is 200?
Yeah, 200. Do we have anything longer? I mean, this is a biphasic. Does this one go higher? The Zols I know go higher.
This one can go higher. What do you want?
But is this biphasic?
Yes, these are
Some
biphasic.
literature to support going higher now than 200. Let's
Go. What do you want to
do
do? Then?
300.
All right.
Just keep going. We're gonna do a whole round of compressions before we shock her again.
All right.
Before we do another pulse check. Is it time for epi?
Right here. Yeah.
920. Yes, it
We're
is.
healing the chest right now.
We're
Let's
at
get
it.
some epi ready.
Needle in the chest.
Hear the air come out? Air's coming out of that.
Okay, good job. Good. Watch your needle.
Chris, you want your sheet back?
I'm gonna put it in the chest.
So she basically are bleeding from the EP tube there.
Yes.
So our braking when you stop the compressions would be just like 1 second.
Yeah, we've been breaking because we've had to do this all the time.
I agree.
So you can
Charge.
Good.
Oh,
Yeah,
y'all
continue
clear and you guys move.
So she's charged now?
Yes.
So
Okay.
Y'all.
No, not yet. Let's keep going. How many minutes are we on this round?
this round. We use it.
okay, hands off for a second. You shocked?
Yeah, charge. No, not charge. Just keep it charged.
It's going to keep ringing until I use it.
I know, that's fine.
All right.
I don't have a pulse. What's it look like?
Clear. Refib. I'm clear.
Okay.
Shot.
Go ahead.
Right.
Resume compression. Yeah, I just needled her. She let himself. Okay. All right, let's get someone else to do compressions. Are you getting tired?
Yeah.
Okay,
I'm on the wrong angle.
let's go. Resume compressions. Go ahead. Just watch your fingers come over here. You good, Jed?
Yeah, I'll just stop you. Tell you when to stop, I will.
Where are we on epi?
It's gonna be another minute before the next
All
one.
right, let's push another. Hold ventilation. There's no move. There's flicker is all. And these asystole. Let's resume PA or asystole. Let's resume compressions. Well, we could give her another bicarb, but it's not going to necessarily
What do you need?
improve.
You want another epi?
We'll go ahead with another epi for now. Let's get this.
We're getting a
checked in,
shitload of
and then we're going to need to go back through everything, see if there's anything else we can fix right now.
All right, gonna call it.
What does that mean? I mean, nothing. It doesn't. The studies like say it is nothing. Well, no, they said it's not the same as nothing. But I mean, just
6.7. He started off at 37.2 and he's now 36.7.
Okay.
That's our target.
Our target's
that
34
he is at, yeah.
and at 36.7. Okay. Good job, guys. Good work.
He's not going to get one for you?
Yeah, we don't have a gas.
Good. I know where we're at.
Get rid of
Once we lost vital, probably should have like checked for a